Hello, everyone, and welcome to the Osteoarthritis Action Alliance Lunch and Learn for September. My name is Kirsten Ambrose, and I appreciate all of you taking time to join the presentation today. Before we get into it, you'll see that we have a poll out there today, something we're trying a little bit new. Just wanted to get an idea of who is in the audience, in part to help our presenters direct their talk a little better, and in part because we're just plain curious. And most of you have already voted, actually, and it looks like we have quite a few allied health professionals. They make up the majority of our audience. A few research scientists, health professionals, and students are all about the same percentage of our attendees, and then last but not least, our distinguished people. So thank you for participating in that poll. I'm going to go ahead and close that now so that we can move on to the presentation. Okay, so I also wanted to remind everyone quickly that by default, all of you are muted for the duration of the presentation. Once we're done, I will unmute everyone for the question and answer segment. Of note, you should see on your screen an audio PIN number, especially if you dialed in by phone. You must enter that PIN number so that I can, in fact, unmute your line if you want to ask a question. So with all of that, I'm pleased to introduce our tag team of presenters from Utah State University. We have Dr. Dennis Dolny, who has a PhD in physical education from Kent State University, and following a 24-year career at the University of Idaho, became the head of the Department of Health, Physical Education, and Recreation at Utah State University. Dr. Dolny has studied the acute effects of vibration exposure on subsequent muscle power output, developing techniques to monitor skeletal muscle activity during walking and running in water. His current research projects involve the use of aquatic exercise exposure on energy expenditure, joint discomfort, and perceived effort in overweight subjects and those with osteoarthritis, as well as the role of hydrotherapy in rehabilitation and conditioning in the elderly. Next, we have Dr. Eadric Bressel, who is a professor in the Health, Physical Education, and Recreation Department at Utah State. Along with his background in exercise science, Dr. Bressel holds a doctorate of education, in biomechanics and is the director of the Biomechanics Laboratory. His lab researches relationships between anatomical structures, mechanics, and injuries and how they pertain to rehabilitation for people with disabilities. He also focuses on aquatic-based research for a number of applications, including aquatic therapy for spinal cord injury, stroke, obesity, low back pain, osteoarthritis, and strength conditioning. Welcome, Drs. Dolny and Bressel. We can proceed with your presentation on aquatic exercise interventions for people with osteoarthritis.
Thank you, Kirsten. I'm Dennis Dolny, and I'll take the first portion of the presentation, then my colleague Eadric will follow up with the majority of the presentation. The topic we're going to focus on today is a very common problem in America and throughout the world, dealing with individuals who have diagnosed osteoarthritis. As you all know, in individuals with diagnosed osteoarthritis, we have a number of relative deficiencies relating to the neuromuscular and anatomical structures, especially of the lower extremity in these individuals. Therefore, we may have some limitations in the ability to recruit and perform lower extremity movements such as walking, climbing stairs, and performing daily living tasks. We also see when individuals perform these types of tasks, we end up creating a condition where the movement with pain and joint discomfort may exacerbate the condition and further accelerate the decline in functional status. Therefore, these individuals need to participate in a regular physical activity exercise programming targeting improving the functional characteristics, especially of the lower extremity. with these individuals, they experience a tremendous amount, typically, of pain and joint discomfort while performing physical activity on land. So therefore, a variety of efforts are made to mitigate this pain and discomfort. For example, on land, people may ride a stationary bike or do other forms of exercise where body weight support is present. Another great avenue of reducing the effects of gravity on the human body is by having individuals perform activity in the water. And as this slide demonstrates, in a recent study we performed corroborating earlier research, that you can significantly reduce the joint loads on the lower extremity, upwards of 39% unloaded when a person is at the level of their greater trochanter or relative hip area, and upwards of 68, over 2/3% unloaded when the person is immersed to a level at the xiphoid. The second benefit of water is that even though the body weight is unloaded, benefiting the joints, we also have the ability of moving through water, which will add to a relative resistance of the lower limbs while walking. In this example, we have individuals walk on a water treadmill, and we have added the resistance applied to the torso by having water jets, not unlike what you might see in some type of a therapeutic pool. And as this slide demonstrates, while walking at a consistent speed of 2.3 miles per hour, very common walking speed for sedentary individuals, you notice as the jet percentage of the jet capacity increases, you can double the metabolic cost of walking in water. So therefore, one of the benefits of the use of water jets in water is that even though a person may be orthopedically restricted in their ability to walk at a given pace in water, the water jets mimic a pace that is significantly faster than what their joint limitations restrict their pace to. In this example, you are literally doubling the metabolic effort, which also means doubling the caloric expenditure. Now, traditionally, aerobic or endurance type exercise training focuses on a brief warm-up period, followed by a minimum of usually 20 to 30 minutes of moderate intensity exercise, as designated by a targeted zone in about the 65 to 75% of a person's aerobic capacity, or VO2 max or peak, and then a perceived effort, approximately 14 or 15 ratings of perceived exertion on the traditional 20-point exertion scale, where 20 would mean the hardest possible exercise anybody could ever perceive themselves performing. Perform the majority days of the week. This would represent a traditional exercise prescription as endorsed by the American College of Sports Medicine, American Medical Association, and the Center for Disease Control. In recent years, a new, more novel approach to performing training takes part in what has been termed aerobic interval training, or high-intensity interval training. And this differs from the traditional method, whereby you take relatively short, brief, but intense periods of exercise, interspersed with, again, short, brief recovery periods, so that following a warm-up period, you see a relatively short total exercise duration of as low as 5 minutes up to approximately 15 minutes, interspersed with brief periods of recovery. This technique has been proven to be very effective on land using cycloergometers and treadmills in sedentary, apparently healthy individuals and in diagnosed heart failure patients. So This has been proven to be effective on land for a wide range of conditions and functional capacity individuals. But again, keep in mind the intensity is approaching 90% of a person's aerobic capacity. So it is short term per bout, but relatively very intense activity.
Excuse me, Dr. Dolny.
Yes. Mm-hmm.
I'm sorry to interrupt you. I'm having trouble viewing your slides, and I wanted to be sure that you had enabled a screen sharing on your end.
Okay, we'll take a pause here and we'll check that. So just give us a second.
Sure, I apologize.
Have any slides appeared yet?
They have just now, yes.
Okay.
Well, that helps.
Okay.
There you go.
So I'll be happy to back up one or two slides if that would help, Kirsten.
If you think it would help for some context, I apologize. I was trying to see if there was a better way rather than interrupt you.
Okay.
But
So, just to reiterate, we'll stop there. Traditional aerobic exercise uses a very moderate intensity, continuous exercise paradigm, which is very common, broken up only when a patient or a client is fatigued or experience pain. Currently, more recent evidence has suggested this high-intensity interval training protocol can prove to be very effective for a variety of clients, and now you see where the intensity approaches about 90% of a person's aerobic capacity, interspersed with brief periods of exercise. Therefore, this aerobic interval training, or the high-intensity interval training, again, has been proven to be very effective with apparently healthy adults, where the VO2 max improvements after 12 weeks of training have exceeded the more traditional endurance-type training, and also in heart failure patients, once again demonstrating the efficacy of using what appears to be a really unique, intense training, even with the most sedentary or deconditioned intervals in our population. Finally, in individuals with osteoarthritis, there's a need to promote exercise where it helps with balance, postural stability, because these individuals, and in all elderly populations, they tend to lose their capacity for postural stability as they age. Now, this led us to conduct a study that Eadric will describe for us in determining how effective might this high-intensity interval training be if performed in the aquatic environment.
All right, well, hello. A little bit about our participants. We did have 18 individuals diagnosed with osteoarthritis. They had a duration of having that arthritis for a mean of about 6.8 years. And we had these, I guess, prescribed to us from a local rheumatologist, and they were confirmed for OAAA through radiology techniques and specific algorithms and so forth. And they tended to be in the moderate to severe range. So keep that in mind. And again, as you can see here, 100% of them at least had one of the knees, and some of them had the hip as well being diagnosed. So a little bit about our design. We had a pretest, what we call a double pretest post-test design. And so this was quite nice for having a control condition and also for allowing us to assess the reliability of our measures. And so that's when you see the red boxes here, pretest 1, pretest 2. In between those two was about a 4-week period where they kept their typical daily activities that they were doing before the study. And we did then had our 6-week training period, and this is what I'll talk a little bit about, and then we did our post-test. So the key features again were of this particular program was again the high intensity interval training for these folks and using the jets for causing perturbations. This is a little bit similar to the graph you just saw, and in terms of what they would experience when they came in on one of those training sessions. So we would have them warm up on the treadmill. And I will get to those pre-test, post-test measures in just a second. I just want to emphasize that those were all done on land. We're by no means sort of using this as long-term. This is an initial program to get them sort of prepared for doing land exercise. And so this is excellent, again, for those who are have so much elicited pain on land that they can't do this, these kind of programs initially on land, so they do them in water first. So we have the warm-up. The perturbation period here, you can see, this is where, I just want to go to my next slide and then I'll come back to this. This is where we utilized, in this case, water jets. Now I want to emphasize here, we use these water jets, however, you could also use sort of a manual current produced through, let's say, a paddle board or something like that, and I have a slide here that will help you appreciate that. Again, these currents were meant to essentially push the people and destabilize them so that they could then challenge their balance. If those individuals who this was, let's say, easy, which it wasn't for most, as you can see this person catching themselves, they would often then use a tandem stance or even close their eyes to make it more challenging. So we did this for 5 minutes, applying these pushes in different directions. This particular slide here represents some results from an earlier study that assessed how much is that current really causing a destabilization. On the graph over here, the bar or column chart, what you'll notice on the y-axis here, this is how much sway occurs when they are either on land or when they're at the xiphoid at different jet intensities. And notice I put in here the kickboard. So we measured this sort of center of pressure sway using a waterproof force platform you can see in the diagram to the left here. That allowed us to measure the center of pressure sway. We also measured how much velocity was being put out by the jets or the kickboard. And you can see that at 20% jets, these are pretty small velocities, 0.4 to 1 meter per second. And now coming back over here to the bar chart, notice that the kickboard was able to produce a velocity that produced a sway very similar to something between the 40% and 60%. So while you may not have access to jets, you can still provide this perturbation experience in the pool pretty easily without the jets, it looks like. And so after that balance session, then we had them do the high intensity intervals. And again, these folks are anywhere from 30 seconds to about 3 minutes. They were at this high intensity of about 90% of their aerobic capacity. We confirmed this. We mostly use RPE scales during the typical sessions, but we did confirm that they were reaching 90% of their VO2 max. And again, this coincides to something around 17.5 on the RPE scale. And this is just some statistics. So yeah, they're highlighting the point that when they are doing these intervals, here, for example, this is a 75-year-old. She's experiencing jets at about 74%. She's only walking at about 1.8 miles per hour. So she's walking quite slow, and it looks quite easy, but as you know, fluid resistance is disguising the intensity that she's putting forward here. This person, by the way, was not able to walk more than about 5 minutes on a land treadmill when she first started, and at the end she was a rock star. So just briefly, our scores. We did have some subjective scores that we assessed on all our pre-test and post-test. One of them was the KOOS score. This is the knee injury osteoarthritis score. It's like the WOMAC. In fact, you can get the WOMAC score out of it. On the Y scale, notice that 100 indicates no problems at all, and 0 indicates extreme problems. The two lines here on the bottom, I just want you to focus on the pain. That is the pre-test scores here, and those were not different from each other. The 50, it's about 52%. These are, I guess, relative scores of 50, and they reached about 78 on post-test. Now, the KOOS score, a minimal significant change is thought to be 6, and we saw almost 20 as a result of these intervals. So the intervals didn't exacerbate the pain. In fact, they decreased the pain. And this was a subjective score. We also did we also used some visual analog scores to get some immediate pain scores that that supported these results. And these are some of the other subscales. All of them were significantly improved after the 6-week interval training session. We also used the gold standard balance assessment, the NeuroCom, for measuring various components of balance. And again, looking at the bar chart here, we have the 2 pretest scores. These were actually below, and I guess no surprise, these were below what would be expected for normative values. They were about 63, 64. After the 6-week intervention, our scores increased substantially. The effect size for these are about 0.78, 0.63, I'm sorry, on this particular score. And so these were quite nice to see. So clinically meaningful scores were shown here. So it was significant, but it was also quite clinically significant. So a couple other measures, some functional measures. We had individuals do some dynamic, if you will, balance assessments using these limits of stability. And again, our 2 pretest scores are shown on the left, and then our post-test score here showing that they're able to feel more comfortable in moving their center of gravity closer to their perimeter of their base of support. Notice the effect size on this one, again, 0.8, and these are quite impressive when you compare it to previous literature. Another functional score measurement we looked at or assessed was the sit to stand. And again, this measure is essentially how much weight they transfer, and it's showing here that again, we have a significant improvement of about effect size of about 0.7. So the time required to shift their center of gravity was significantly improved after the 6-week intervention. And then we looked at some basic measures here in terms of their mobility. Walking, for example, the 10-meter walk. These times are for the pretest here of takes about 9 seconds, 8.6 seconds. Those weren't different, but after the 6 weeks, again, we saw a nice improvement in their speed, and so it only took about 7.8 seconds, and that was comparative to normative values, which is quite nice, which is about, looks like 9.3, so yeah, quite nice. So we did get a lot of subjective comments. I just want to share those with you, and I'm not trying to sugarcoat it, if you will. These are pretty common with all the participants. You know, one of the big ones that people were really noticing was being able to go up and down stairs, and so that's a really nice subjective comment to see. And some of these people were commenting that, you know, they hadn't been able to walk without pain for some time. So what we can conclude is these balance and pain scores, these functional measurements, tended to improve after the 6-week intervention, but not after that control period. The interval training seemed to be well tolerated. In other words, these participants weren't seeing exacerbated pain by any means. In fact, they were seeing significant loss of pain, which is, again, a key feature of the symptoms of people who have osteoarthritis. Most of them, of course, wanted to keep going, and we have, of course, plans to do post-assessments on these individuals, follow-up assessments to see how well they're doing with these. And one last point I just want to make, you know, with any physical activity, adherence is absolutely critical. You know, once these people have osteoarthritis, it's not like you do this intervention and then, oh, they can now stop. It's not like a medication that they can take and then they don't have to take it anymore. It's a continuous thing. And so adherence is really critical, and we showed 100% adherence with this. So not one participant didn't show for any of their sessions. They made it to every session for all 6 weeks. So those were some nice findings. And so I guess we're looking at the time here, and we have just about 5 minutes left for questions.
Okay, thank you very much. Yes. I appreciate everybody's patience with the functionality here. We're just kind of still getting used to the webinar, but I hope you were able to see the slides in the end, and we can certainly send those around to all of the attendees.